Hey everyone, and welcome to another episode of The Family Couch. Today's guest, I'm so excited to have on, is Robert Taibbi. Thank you so much, Robert, for being on today.
It's Taibbi.
Taibbi.
Oh, it rhymes with baby. It's really easy.
I'm gonna start over. I actually should have asked you that. So it's Taibbi.
Yeah, I got a cousin who's famous who pronounces it a little bit differently. He's on the news all the time.
Nice.
He's able to do that. Okay.
All right, I'm start over.
Taibbi.
I want to say it
Start
right.
over. Start over. Okay.
See, editing.
There you go.
Hey everyone, and welcome to the new episode of The Family Couch. I am so excited to have today as our guest, Robert Taibbi. Thank you so much, Robert, for being on with us today.
I'm excited about doing this. Thank you.
And in today's episode, we'll be talking about family therapy and sort of demystifying what it means, whether you are looking for going into family therapy or you are a professional who is doing this important work. We really want to talk to kind of one of my influencers and someone who really encouraged me and influenced the work that I do, and to really talk about some of what it means to be a family therapist and what it means to really create change in families. So I'm excited to get into this discussion.
Great.
Robert, can you tell us a little bit more about who you are and what you do?
Sure. I've been in practice 42 years. Most of it's been in community mental health. And so I've worked with a lot of families who are often struggling, who are coming because someone told them to come, folks who are tied up with social services and the courts, a lot of poverty issues. So that's been a big bulk of my work. The last 10 years I've been in private practice. I've written 10 books, including the one you're mentioning, on family therapy, couples therapy. In the last few years, I've moved towards being interested in brief therapy. Again, partly because a lot of my work in community mental health was exactly that. A lot of folks aren't going to be coming for a year to talk about their childhoods. They're coming in crisis. They're coming because they want, results now.
Right.
And so I've been interested in that. And then I've been interested in a couple of the other books I've been writing around that either have been around brief therapy. How do we do it? Action-oriented and very behavioral. I tend to be CBT and very behavioral. So I give people homework. Here's things to try. Here's how to change things. When we're talking about families, we're talking about changing patterns rather than figuring out who's got the problem and who's the bad guy.
Yeah.
So I kind of focus on that. And then some of the other stuff I've been writing about has been like, how do you do a first session to make it effective? Because people come oftentimes, if they've never been in therapy before, they come in with expectations. And in our age of instant information, and Dr. Phil, 20 minutes. They want you 20 minutes to tell them what's wrong and what they got to fix.
Yes.
And if they come into you and you're going, well, thanks for coming, and we'll pick this up next week, or I need to see your child 3 or 4 times before I can give you any feedback,
right,
they're going to get frustrated.
Yes.
And they're not going to come back. So I think it's important for us to we don't have to, we can shape the expectations, but we need to be sensitive to what people need. So a lot of the work and a lot of thinking I've been doing the last few years has been around that type of work.
Right. And, I want to kind of talk about these ideas of the expectations that we have for doing, especially family work, because like you said, we live in this age of Dr. Phil's and reality TV shows where the reality therapist comes on and gives a quick, intervention. So how do you help from a client perspective? How do you help manage those expectations in those first sessions?
Sure. And again, I think the critical one is going to be the first session. So a couple of things I do is ask people if they've been in therapy before. And then I usually ask, how come you're seeing me rather than going back to your old therapist?
Right.
And I listen carefully to what they say next.
Yes.
Because that says a lot. Because oftentimes they'll say, oh, she was really nice, but she didn't really say much, and we just kind of talked about the same things we talk about at home. That tells me very quickly, don't do that.
Right.
Don't just sit there and nod your head and kind of do that. They want something more decisive. So I'm looking for that, and I'll ask people. What do you have in mind? Now, a lot of times folks have what I call skewed expectation. I've had parents, you've probably met them too. They just want to drop the kid off.
Yeah.
and say, I'll pick them up in an hour, and I'm going to be going to Walmart. I'll be back. And so part of it is helping them understand what the process is about. So I take some time doing that.
Yeah.
And it's important for me to know by the end of the session that we're on the same page.
Yes.
I work hard to try to give people, the analogy I use in a couple of my books is what happens when you go to your doctor. If you go to your family doctor, you wake up in the morning and you have this huge rash on your arm and you're going, oh my God, what is this? And you're freaking out. And you go on WebMD or something and you see these horrible pictures. And now you're really freaking out. And you go to your doctor and you're already anxious. And you're already looking for something.
Yep.
And what does your doctor do? Well, you know what your doctor does. Your doctor looks at it. She looks at it under a magnifying glass or whatever. And then she asks you like a series of questions. Where you're out in the woods. Have you put anything on it? Does it itch? Does it get hot? Does it do whatever? And then she says, I think it's this.
Right.
I think it's contact dermatitis. I think it's that. It's not some African mange you read about on WebMD. It's probably this. Here's some cream. It's a sample. Use it for 3 days. And if it doesn't get better, let me know.
Right.
This is done in 15 minutes. 15 minutes. You're out the door. And do you feel better? Absolutely. You feel better. Why? Because your anxiety's down. You got some information. Somebody has kind of looked at it and they have an idea about how to treat it.
Yeah.
Parents and families need the same thing. They don't want you coming in and saying, well, that was great, and thanks for talking, and we'll meet again next week.
Right.
Because they don't know what's going to happen.
Right.
So I think this is important. I think this is important to be sensitive to what folks want.
Right. And I love that piece of it that you talk about, because I know sometimes in therapy, people sometimes, don't understand how medical it can actually be, right? They want to talk, and people tell them about talk therapy. But I love that piece of, we need to really think about what the family needs and meet them where they are, right? That's what I was taught. You meet your family where they are. And I see that that's kind of where you start with. So when you do talk about the process, though, how do you explain that process to a family? So you've talked, you've understood where they're at, what they need, and now you kind of have a good understanding, okay, this family is going to need da-da-da-da-da. How do you walk them through that process and help them understand the length or how long they might need to work with you to get their goals, to meet their goals?
Yeah. Again, one of the things that I've been working on in the last few years is how to do assessments fairly quickly. What I wind up saying to families and to couples, because I do a lot of couple work as well, is somewhere within 15 minutes or 20 minutes of after they kind of say why they're here and what their story is, basically what I wind up saying is, and I don't say this bluntly, but what I wind up saying is, I don't particularly care what you talk about. What I do care about is, why are you sitting on my couch? What keeps you from solving this problem on your own? And what often happens is, for example, for couples, they never solve the problem on their own because they're afraid to talk about it. Or they do talk about it and it goes Jerry Springer in 5 seconds and everybody's blowing out guns and knives. And then they don't want to circle back to it because they're afraid it's going to become a hot topic. Or for parents, they disagree. You met them, I met them. They disagree. One parent's really tough. The other one's polarized and doing the real easy stuff. They're not on the same page. One thinks the kids should go to bed at 11 o'clock at night. The other one wants them to go to bed at 7:30. And they're not agreeing. And they're not agreeing. So what can't they do? Where do they get stuck solving these problems? It's about communication. Sometimes it's about information. Sometimes they're treating their 15-year-old the same way they treated him when he was 8 years old. And so the kid is rebelling, and the kid's giving him a hard time because he doesn't want to go to bed at 9 o'clock. Or whatever it is. So part of it is about that. How can I educate him about what's developmentally appropriate? How can I work with them and get them on the same page so they're not, so the kids aren't splitting and kind of squeezing through the cracks. So we're trying to figure this out. And then, if you can do this kind of quickly, where do they get stuck? And I even asked that question. Tell me how this goes. Where do you get stuck? When you guys try to talk about bedtime or talk about, your 14-year-old daughter going out with this guy, whatever it is you're concerned about, what happens? And then I want to see where they get stuck. Communication, different values, emotional regulation, what happens? And then how do we fix that? That we can give them feedback on fairly quickly. And then because I tend to be behavioral, for me, it's about, here's some homework.
Yes.
Here's some homework. So, for example, if I see parents or couples where they do have a hard time communicating, and they have a hard time because one person's the turtle and they're afraid to speak up, and they're married to the other person who's always playing offense, or they're trying to have these conversations at 11:30 at night when they're both dead tired, or somebody's had 3 beers, or whatever it is. One of the things I say is, okay, for homework, what I'd like you to do is you're gonna set aside time for what I call a business meeting. You're not going to do it at 11 o'clock at night. You're not going to do it after 3 beers. You're going to do it when you're both sane. Right. Because what happens when you get upset is your prefrontal lobes go offline.
Yes.
It's the physiology of of anger and emotion. And so you're gonna set aside a time. You can do it 9:30 on Saturday morning. You have a cup of coffee. You're gonna park the kids in front of the TV and watch cartoons. And you're gonna pretend you're at work, because people know how to act at work.
Yes.
Right? They don't go whopping their cubby mate up the side of the head because the person left, their cup on their desk.
Right.
So they know how to do this, but they don't do it at home because they know how to push each other's buttons. And because their defenses are down or whatever.
Right.
So what I say is, sit down. You're going to have an agenda. This gives each of them time to figure out what they want to say and why they want to say it. What's the point of the conversation? What's the problem we need to fix? What is it I want the other guy to understand? So the turtles, the people who are afraid to speak up, have time to work this out.
Right.
They're not thinking on their feet at 11:30 at night and freaking out.
Right.
And the other person gets a chance to decide, how important is this really? I was really upset Wednesday night when my husband did this. Now I was just in a cranky mood, and it's not a big deal.
Right.
You have an agenda. You're going to do it for a half hour. You're not going to do it for 5 hours because everybody's going to decompensate and go crazy.
Yes.
So you can do it for a half hour, and you're going to pretend you're at work. Your job is to stay sane.
Yes. Yes.
I'm going to pretend I'm not going to. And if it starts to get too emotional, your job is going to stay cool. If it gets too hot, you're going to stop. But the idea behind this is giving them having some success in having a conversation.
Yeah.
Some success in being able to problem solve. Now, again, some families, some couples, they get stuck because they don't know what to do, because they don't have the skills, because they do get overwhelmed. And they really have a hard time kind of just figuring out what they're thinking.
Right.
If that's the case, that's what we use therapy for.
Right.
Bring your problem into therapy. We'll walk it through. I'll slow it down.
Right.
I'll be the one to make sure that Ed hears what you're saying before Ed starts to get too cranked up.
Right. Right. And so in family therapy, right? So we've got at least 3 people in the room, 2-3 people in the room, right? And so when you're managing all of these ideas and you're helping everybody figure it out, how do you help somebody who says, we tried this at home, like you just said, we tried this, we tried to have a family meeting, we tried to talk, how's this different?
And then I'm going to say, you tell me, how come you're sitting on my couch? You tell me how it's different. What happened when you had this conversation at home? We're going back to the same thing. Yeah. What happened there?
Yeah.
And they go, well, because I got really angry. He always brings up the stuff about last year when my mother said something at Christmas, and it just pushes my buttons. Now we're going to talk about why it pushes your buttons.
Right.
Or what does he need to stay instead so you don't go down that road.
Right.
So I want to kind of manage it. And again, my idea and the family therapy is we're not looking for who screwed up. One of the things I say a lot in my trainings is kind of what I just said. When families and couples come into therapy, a couple of things happen. But one of the basic differences between them and me is that they're talking the language of content. They want to tell their story.
Yeah.
Right. They want to get the story out there. And what they tend to do, especially if they're angry about stuff or emotional, is they start to get upset. And what happens when you start to get upset is now you get tunnel vision because your prefrontal lobe shut down, and you're going to make your point. This guy's going down. And what they tend to do is they stack up content, right? Oh yeah, Tuesday. You want me to read the text? I'll read the text to you right now. My mother said, and they're trying to make their case.
Right.
The problem is no longer in the room.
Yeah.
The problem is now the emotion.
Yeah.
We need to put out the fire.
Yeah.
So they're talking about content, and what often they're looking to me to do is to play judge.
Yes.
They want me to be Judge Judy. They want me to go, you're right, you're wrong, you're crazy, you're saying, whatever it is.
Right.
I don't care about that. I'm back to process.
Yeah.
Can you guys tell you're heating up? Can you guys tell you're no longer talking about Johnny what time he needs to go to bed? Can you tell that the other guy isn't hearing you and you're whatever?
Right.
I want to focus on that as a starting point.
Right.
And slow them down. And my job is to help them do that. Help them become aware of it. I do not want to have people, I've had folks who've been in therapy before, and I have a real hard time with this, and at some point it becomes, in my mind, an ethical issue where couples and families come in and do the fight of the week. They'll come to therapy for 20 years. You know, they go, how was your week? They go, great. Can we talk about Tuesday? So we had this thing on Tuesday night, and blah, 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 blah. And you kind of sit there and you kind of moderate and you do this and whatever. And you go, okay, well, it sounds like we got a solution. We're going to do this, right? And they go, yeah. Next week they come in and do it again. I don't want them to do this.
Yeah.
I want them to learn the skills that they need to be able to run their lives.
Yeah.
I want them to be able to figure out where they get stuck. And the way they do it is by kind of hopefully hearing what I'm doing.
Yes.
So after a few sessions of me saying, hold on, can you guys tell you're getting offensive? Hold on, you guys are going off track. Hold on, Mary, can you tell you're starting to get upset?
Right.
Eventually, they'll start to do it themselves.
Yes.
And then they're good. Once we figure out, the reason I can do brief therapy is once we figure out where people get stuck running their lives, and usually it's around being sensitive to certain emotional wounds, being not able to self-regulate. It's about learning certain skills that they need to learn to be able to effectively deal with their kids. Once we figure this out and they do it, and we give them homework to practice it, they're done.
Yeah.
Now, they're still going to have problems in their lives.
Right.
Stuff is still going to happen to them, but they're not going to have to run to therapy every time.
Yes.
Because they know how to do it. They're not going to do all the stuff and fall into all the potholes they fell into before. They get some in trouble.
Right. And it's, I was going to say, it's you preach me choir. This is kind of my friends, as I talk about this stuff, I say, I'm essentially trying to put myself out of a job, essentially. Like,
that's right.
I'm trying to get families to talk. I'm trying to get parents to feel confident, right, as a parent coach, so that way they don't have to come to me every time their kid says, I'm not going to do a chore. They can say, let's take a step back and figure out how to work this through. And I love that process that you just took us through. So one thing that you mentioned that I kind of want to transition into now is, as a professional, how do you do that? Because I hear that, I know that when you're starting out, families can be very overwhelming. Couples can be overwhelming. So when you're sitting there and they are bringing you as a professional fight of the week, how do you get beyond moderating and get into that process that you just spoke to? How do you help clinicians do that? Or what do you have for clinicians to do that?
Yeah, I think part of it is they need to kind of train their own ears and not get, what happens for my experience with people who are less experienced is they get caught up in the story.
Right.
They do. They get pulled in. They get pulled and they go, what time was that on Tuesday? And what was that? And what'd you say that, what'd you have for dinner? And the problem with that is they get caught up in it, and now they get overwhelmed by too much information themselves, and they feel like, just like what happens is they replicate the problem. Right. They start to feel the same way the parents do. Yeah. We have to sort all this stuff out. We got to figure out all these facts and all this information to try to figure out what we need to do differently.
Right.
And so part of their training is to be able to catch that, to look at patterns, to look at process, to see where things start to break down and not get hooked into thinking they got to unravel the story.
Right.
And again, that's a training thing. This is a training thing to be able to hear stuff, to look at patterns, to not do that.
Right.
The other part that I think helps in terms of just clinicians and their anxiety is one of the things I talk about in a couple of my books is it's kind of what happens to your doctor. When you go to your doctor and you show up with the rash, she is not reinventing the wheel.
Right.
She knows, given what you're producing and where you live, you don't got an African mange. She knows it's going to be contact dermatitis because of poison ivy in the woods.
Right.
She doesn't have to go through 500 things. And she has in her head 3 things she knows she can give you to fix it.
Right.
So she has this in mind. That's why she gets it done in 15 minutes.
Right.
As a clinician, we need to have the same thing. It's not cookie cutter stuff, but you need to have in your head and even think about it before people walk through the door.
Right.
If I see a kid who's having problems with night terrors If I see a 15-year-old teenager who's starting to have eating disorder kind of stuff, I need to have a roadmap in my head for what I can do.
Right.
I need to know this. It isn't about getting into the weeds of what time was it on Tuesday and what did you do this or whatever, but I need to have a path for this. And this is something we can teach people.
Yes.
We can teach people how to do that.
And I love that piece of it. And I think, and you can tell me, your professional opinion, do you think this is why maybe clinicians might need to maybe niche a little earlier, maybe knowing, okay, I like families, I like couples, or do you think they should say, I'm a jack of all trades? Because I find that if you're a jack of all trades, it's harder to have that kind of kind of clinical, spin wheel, where if I know I'm working with families, I do understand the common things that plague families, or if I am working with couples, I kind of know the common things that plague couples. But if I'm seeing everybody, it makes it hard to get used to these patterns, so to speak.
Sure. And you're right. I mean, you can't cure everybody in the world.
Right.
So certain things, I don't work with people who have psychosis.
Right.
I don't do that. I used to work with people with eating disorders. Now I don't as much.
Right.
Just because they need a whole lot of focus. Right. They need a whole lot of time for a whole bunch of stuff. I work a lot with people where I'm good with anxiety. I'm good with family therapy. I'm good with couples therapy. And so I kind of stay with that.
Yes.
Part of that is also being fair to clients.
Yes.
I don't want them to say, sure, come on down, and I'll see anybody, anywhere, anytime.
Yeah.
And they're not going to get what they need. Right. It's kind of like going to your family doctor. Your family doctor can do a whole bunch of stuff.
Right.
At some point, when you come back 3 days later and you still got the same rash, she's going to go, I'm going to send you to a dermatologist.
Right.
And the same thing here. If I see somebody who I'm concerned they have an addiction, or they have untreated ADHD and need to be tested, or they need to see a psychiatrist just to get a consult on medication, they got to do it.
Yes.
That's part of my responsibility.
Yes.
I mean, that's an ethical responsibility.
Yes.
You don't treat people you can't fix.
Right. And one of the things that I'm just kind of throwing out here, this idea of community mental health, because you've worked in it, I feel like community mental health sometimes trains clinicians to see anything, because you end up seeing whoever comes to the door.
They have to. Right.
And so how do you help clinicians figure that out, that early training where I am in community mental health and I'm seeing whoever gets an assessment on my desk? How do I learn how to transition into, maybe once I get licensed or once I get more experience, how to really kind of hone in on a set of skills or a set of interventions or a specific niche that I feel comfortable treating?
Well, I think you answered your own question.
Okay.
Yeah. What am I comfortable doing?
Yeah.
What kind of things bring out the best of me and my skills?
Mm-hmm.
I enjoy doing families and couples because I like the high energy of it.
Right.
I can kind of get into that, and I enjoy kind of having a lot of people in the room, and that's fine. Where somebody else will get overwhelmed.
Right.
And my clinical models may fit that.
Right.
It's active oriented, whatever. Right. If I was more psychodynamic, if I was more historically oriented, if I was into that kind of stuff, I would probably want to work with individuals.
Right.
And again, over the course of your career, it changes.
Yes.
You work with kids for 10 years, and then you kind of get tired and you want something different. That's fine. That's fine. But I think the starting point is, what am I good at? What do I enjoy dealing with?
Right.
Again, we're not doing plumbing. So a lot of this is not, it's not computer repair where it doesn't matter what I do.
Right.
It is. You've met them. I've met people where they go, I don't want to work with kids who've been traumatized.
Right.
Because it stirs up just too much. It's just too sad for me.
Right.
It just stirs up too much of my own stuff. Or I do want to work with kids with trauma.
Right.
Because it is about me, and I feel like I can make a difference.
Right.
Because I understand, what it is without over-identifying. But that's fine. Again, this is people work.
Yes.
You're getting into it not to make $1 million. You're doing it because you have a passion about something.
Right.
So follow your passion.
So
and they get the training you need for it.
So I'll say this to the clinician who is in community mental health, to the clinician who's like, I want to do, they're maybe working at CPS, or they're working in a large nonprofit where they do kind of have to deal with whoever comes to the door. How do they begin to hone that skill for themselves, whether it be if it's family or family work or not? How do they begin to hone that skill with everyone who comes in the door? What would you say to them? Well,
I'm going to say my experience is it's not everybody's going to come through the door, but it's still not the whole world. You're still going to get certain profiles.
True.
You're still going to have people who are similar, in either, they're their backgrounds or their level of whatever, so there's certain kind of problems they have. So you don't have to do it all.
Right.
And even in those kind of agency kind of settings, you're going to have a child team, you have an adult team, you're going to have a addictions team or whatever. So they can't specialize.
Yes.
So that's, the other part though is if they're saying unfortunately, through nobody's fault, you have a lot of folks who get out of grad school, they work in an agency because they have to get licensed and they're not licensed yet, and they have to get the supervision.
Yes.
And they don't have the skills, and they're getting hit with the worst kind of folks in the world.
Yes, definitely.
And so they feel stupid and they feel overwhelmed and they feel like I can't do this, and they kind of get whatever. And oftentimes, just because of the nature of the economy and the agency, they don't have money to do training.
Yes.
So they're kind of flying by the seat of their pants.
Yes.
For a couple of years. I think it takes, 10 years.
Yeah. To
kind of go from being a novice or a new graduate or something to feel like I got my sea legs.
Yeah.
Where I can do stuff. I'm not overwhelmed by stuff. I'm not, when I look back on when I was in my 30s and late 20s, I go, oh my God, those poor people. I did a good enough job.
Right.
But I look back on it now and go, wow, compared to just maturation and skills and the fact that I'm older.
Yeah.
Back when I was in my 20s, I was talking to people, look at my parents. Does that freak you out? Yeah. Absolutely. You can ask them about sex. They're gonna give you a hard time about. They go, you got kids?
Yes.
And you go, well, what do you know about kids? They do that all the time, and you're feeling.
Yeah.
You're 26 years old. You're gonna go.
Right.
Get overwhelmed. So, and there you need support. There you need training, but that's where you need supervisory support.
Yes.
Where somebody says, it's okay. Don't worry about it. And if they start to kind of give you a hard time next week, here's something you can say back.
Right. So in your experience, let's talk about that just a bit, because I know that there are a lot of clinicians who are like, I want to do this work. I'm just kind of starting out, either right out of bachelor's, right out of master's. I really want to do this. What do you help them, or what would you say to help them kind of sustain them for that first decade or those first 5 years where they're learning? What can they do to manage that anxiety? What can they do to kind of feel like, even though I'm learning, I'm not stupid or I'm not a failure, I haven't picked the wrong profession?
Right. Part of it is a sorting kind of sort of system. What we were saying before. Yeah. They're going to get in to do certain work. They're going to like it. They're not going to like it. Some folks are going to say, I don't like the client work. I thought I would, but I don't. And I'd rather do administrative something. Right. Or like do community organization, whatever. Right. So that's going to be part of it. The other part is they're going to have to, to reach out and get the support they need. Either you both get training, so they're not feeling like they're flying by the seat of their pants every day.
Right.
And to be able to kind of get support, either from colleagues or ideally from a supervisor, to help navigate these difficult days.
Yeah.
And then they need to have, a balanced life.
Yes.
Because this is a high burnout kind of profession. You're talking to people all day long who are struggling with problems. And I do a lot of training on supervision, and I've written a couple of books on that. And one of the things we talk about in the workshops I do in supervision is, realizing that oftentimes the personality of people who go into these kind of fields are people who are generous, who are giving, who tend to be conflict avoidant, who want to make the whole world happy.
Right.
And they are a danger of getting burned out.
Yes.
And supervisors need to be aware of this. They need to be aware of what these folks are internally struggling with, so they can be the support they need, and encourage them not to be able to set boundaries.
Yeah.
And again, when you combine it with what they don't know, what happens is you get this parallel process going on where Mrs. Jones walks in with 10 problems. I got my kid who's got ADHD, another kid got thrown out of school, my husband's drinking too much, and my mother just broke her hip and whatever. Yeah. And what happens is this person comes into supervision and go, you wouldn't believe what's going on with this family. We have to fix this, and this.
Yeah. Yeah.
And then they start to feel like, I got to fix 10 problems out there.
Yeah.
And one of the shifts, and now we're back to what we've talked about before, one of the shifts and one of the things they need help learning is, I can't fix all those 10 problems. The only power I have is when I'm talking with Mrs. Jones in the room. But what I can do is help Mrs. Jones figure out where she gets stuck solving her own problems.
Yeah.
So all these 10 problems now become 1 or 2.
Right.
This is a skill issue, and this is a sort of paradigm shift that people need to go through.
Yeah.
But this is where they need help doing that.
Yes.
Because if they start to constantly feel like I have 10 clients who are like Mrs. Jones who each have 10 problems, man, I got a lot of work to do.
Yes.
I got 100 problems to work on every week.
Yeah.
You're not going to make it.
Yeah.
You're not going to make it.
Definitely. So I know, again, I'm just, even as a clinician myself, I'm like, wow, I'm just getting so much insight to my own work from listening to you, which again, I think that's why your book talked to me so much when I was in grad school. You're doing family therapy work because you have this insight and this expertise that helps clinicians feel like, okay, I can do this. And I think it even helps families and the people who come to you feel like, okay, we can do this. We can get through this. So I do want to give you a space, though, to let our listeners know more about how they can get in contact with you. If they want to know more about your books or more about the trainings you do, how can they do that?
Sure. I have a website. It's my name. It's pretty simple. It's Bob Taibbi, BOBTAIBBI.com. You can Google it. And so it has a website that has some articles on it. It gives kind of background kind of stuff. It tells you about my practice here in Virginia. I also work with I have videos, DVDs on couples therapy, family therapy, and supervision. You can get these through HESI.
Nice.
Throw them on there. There's a couple with Networker. Psychotherapy Networker. And then I also have bunches of articles. I have about close to 200 articles on Psychology Today blog.
Nice.
Called Fixing Families.
Nice.
It has a whole bunch of stuff on parenting and anxiety and couples stuff and all kinds of stuff. There's plenty of stuff out there.
Lots of your expertise out there.
There's stuff out there, yeah.
Yes.
And if you, there's a link on my website to my email address.
Okay.
If people have specific questions, they can just write to me.
Nice. That's very generous of you. So for those of you who are listening, if you didn't get a chance to jot that down, don't fret. I will have the links to everything that Robert was talking about in the show notes for this episode. So please feel free to reach out to him through those various channels if you need more support on doing this really important work. Well, Robert, I want to say thank you so much. It's been an honor speaking with you. And thank you so much for being on today.
You're welcome. You're welcome.
Bye-bye.
Bye-bye.